See, calcium management using imaging is very important. Otherwise, you will end up like this. You can see there is an hourglass stent there. So it's completely unexpanded stent, got occluded within 2 weeks and came back to us and tried sending, all the luminal devices like NC and OPN-NC and then IVL and ROTA, nothing went in. So I'm exhausted with luminal option, then went extra stent and did a extra stent block modification with knuckle. So if you don't want this, you have to modify block using imaging quite well before you take stent into patient. And this is one score which we can use while deciding on block modification. Anything more than 2, 3, 4, always use. Look at this case, very calcified LMCA bifurcation, and tried sending imaging. This is what happens, it didn't go in. And my first choice, once it doesn't go in, is ELCA doesn't go in, IVL won't go. So best is, rotablation. So I took a rotablator, 1.25, did rotablation, and then again took IVUS in and did an IVUS, but still you can see a lot of calcium within LM bifurcation, and we can also see a nodule here in LCX ostium. And this ostial LMC also, there is a small nodule. So upgraded burr and did rota again into LED, and then again did IVUS. So to my surprise, still that nodule is still remaining, so which you can see. But it is exactly sitting at the LCX ostium. So that's what we can understand here. And we decided to go ahead with ablation into LCX ostium. So this is how, which branch to choose. Again, good is the middle branch. The first branch can cause furrowing and perforation, and this may be inadequate for ablation. So we took a middle branch, and before going into LCX ablation, just fixed LED with stent. You can see after NC dilatation, good fractures, and then stunted, and then went ahead and did a rota into LCX, and then did a pullback from LCX, and we can see a good shaving of nodule, and subsequently, you can see here there is nodule is reduced in its volume, and then we stunted, and we came out, and we can see LCX is still patent because of nodule shaving. And these are the good final MLAs, ostial 8.6 and LMCS 16. And in iodo-ostial calcium, this you can see ostial RCA. So what we can do is, this is LED, which I'm not interested in now. Yeah, so IVUS was not going, so I did a rotablation again, and then post-rota we did IVUS. And what is good here is, you can understand, calcium in ostium, and also you can create a good bias with your guide catheter, which you can understand here. IVUS is far away from the calcium. You can just rotate your catheter, clock, anti-clock, or up and down, and make sure where your IVUS catheter can better align with your calcium, and then you can do rota in that movement. So that's what we did again, and then followed by flextome. That's a rota cut strategy, and then this is final after stunting, and you can see we got a good lumen areas. You can see this is at ostium, this is at ostium, almost like more than 9 mm square. In LMCA calcium, so it's, again, we can do IVUS from both LED and LCX to understand where your catheter is sitting well on the calcium. You can see this is, as IVUS was not going into LCX, LED, I did it from LCX. And you can see it's almost 360 degrees calcium here. So we went ahead and did a rotablation from LED, and then again did an IVUS just to realize how much calcium is shaved. You can see here there's a significant, but there is some chunk remaining, but mostly it got shaved across the LED. The one which is going around the ostium of LCX is still there, but overall, as it is good, so we went ahead. You can clearly see the vessel. We are not able to see here. So, and we stunted it, with decay crash, and this was the final result. To know the adequacy of calcium modification, so sometimes in this LAD you can see this part was very recalcitrant. You can see the calcium, and of course, the calcium score was almost more than 3 here. So we did rota, but still the calcium is remaining like that. And then we did a cutting balloon, and I thought there are a lot of fractures we can see here. So there are fractures, and I thought it is sufficient and went ahead and stunted, but you can see my minimum lumen area is 4.2. So, and that's when, we went ahead and dilated with OPNNC, and we got a lumen area of 7.1 at the site of, that 4.2. So it's important to assess, after every calcium modification, what happened to your lumen area, as well as what is your MSA after stunting. And in this case, you can see nothing was going in. Again, calcium, severe calcium in LAD, and did a rotablation, and then did an IVUS. You can see still calcium is remaining 360 degrees. In fact, the calcium score was almost like 3. So I had to go ahead with IVL, further modification, and we can make sure, whether there are adequate fractures. You can see a lot of fractures, and that's when you can go ahead with stunting, and you'll get a good lumen area. You can see all the lumen areas are more than 100% of distal reference. And in a dissected vessel, so this is a CTO where a vessel was opened, but subsequently they couldn't cross with anything across this point. But there was a lot of dissection here. So you can do an IVUS and map your vessel. So the dissection was sitting here, but the toughest calcium was sitting here. So, and this didn't allow anything to get in. So what we can do, you can just do rotablation up to this point without going into this place where there is an hematoma and large dissection. So you can map your vessel, and you can do ablation despite dissection, and we finally got a good result. You can see all the lumen areas are quite good. And sometimes, when complications happen with your plaque modification, you can see here, there's a calcium 360 degrees. So did IVL, and post-IVL patient went into chest pain and VT, and DC cardioversion done, and you can see there is LAD flow is completely gone. But IVL done in LCX, not in LAD. So what happened, to my surprise, was there was a huge intramural hematoma within the LAD. So it's basically a dissection happened in LCX, and hematoma got spread into LAD. So this is the IMH in LAD, you can see. And when I traced it, you can see this IMH is going into LCX. Basically, it's a LCX IMH coming into LAD. So what we quickly fixed LCX as the patient was unstable, and then came to LAD and did a flex dome to make sure I created fenestration. So we created fenestrations, and then we went ahead, stunting even LAD. And this is the, final result. So paradox sometimes, in this case, I thought of doing a rotablation even before my imaging, but after doing imaging, I thought it's a very short calcium, I can handle without anything. But what happened is I used all the balloons, FlexTome, NC, Scoreflex, everything, but it didn't yield at that point. So finally, I had to do, again, IVL. Since I dissected entire vessel proximally, I went ahead with IVL and, did IVL. And finally, we got a good fractures confirmed in imaging, and then we stunted, and we can see we got a good area, which is quite more than distal reference. To conclude, IVUS is unequivocally important in optimizing, your calcified lesions, and it guides in identifying wire bias for effective ablation of calcium at bifurcation, at calcified nodules, and also at iotoastial lesions. And IVUS guides in understanding adequacy of calcium modification and switching between the strategies to get a good plaque modification before you take shunt out. And IVUS unravels the complications of plaque modification for effective strategization in patient. Thank you.